Hello and welcome to my channel. My name is Peter Abraham. I am a registered nurse with varied background: cardiology, medical surgical, long-term care and rehab, and extensively hospice and palliative care. I'm also on my journey to become a certified death doula, sometimes referred to as an end-of-life coach or end-of-life educator, end-of-life doula. If you're new to this channel, welcome. Thank you for visiting and spending time. In this channel, we talk about hospice-related items, including help from my fellow hospice nurses, holistic nursing topics. So holistic is mind, body, spirit, soul. Not everything's resolvable by a pill or a liquid treatment. There are different ways of healthy living. Chronic illnesses that often turn terminal. Being a death doula, or in my case, working in that direction and indirectly having done it remotely for free for over a year now, as well as being a book author and writing books. My number one bestseller every single month. It's a documentation book for hospice nurses. I like documenting my journey and providing advice for those walking a similar path. So in previous episodes, mentioned about writing a book on how to become a death doula. I'm going to pause right here for a moment because I almost forgot what we do in every episode, and I encourage you to do every day. If you're going to be dealing with death and dying on a regular basis, if you are a type of person where you want it or not, you have storms in your life on a regular basis, it is critical, granted my opinion, to develop resilience. Resilience is that ability to snap back in face of adversity. It doesn't mean that you're immune to it. It doesn't make you a superhuman being. It means that you have the ability to snap back, oftentimes quicker than others. There are times your head may be spinning. I still remember June 14th of last year, which I'm not going to go down that rabbit trail. I still remember where it took me close to a month to recover from what happened that day. So give yourself grace and mercy and forgiveness if it's taking you long to recover. But part of building resilience is, in my instance, and what I recommend that everybody can do, is what are you grateful for? How are you grateful for? It could be as simple as, thank you, God, I woke up this morning. It could be as simple as, I was able to get XYZ done. I trimmed the plants. I learned how to weed whack. I don't care how small or how crazy it sounds. If it has meaning to you and you can say, I'm grateful for it, then be grateful. And I do encourage you to journal. I try to journal on a regular basis. I use notion.so. And even though I do gratitude exercises every single day, there are days where I want to take a special note, like as a for instance, Marie, who runs a remote nursing school. She teaches LPNs and RNs, and I'll put the link in the description below, how to become a remote utilization nurse, how to be a diabetic education coach, how to be a remote triage nurse. And she's been doing this for years. And she, I guess it was a month or two, she purchased this book. This is one of my holistic nursing books, The Nurse's Guide to Motivational Interviewing. And here she shared with me, she is looking at incorporating that book into her courses in May. Keyword is May. I'm not committing Marie to this with this YouTube. But she's considering making it a required read. Wow. I am beyond blessed, even with the thought process. Even if it never happens, just that she would say that this book that I wrote impressed her enough that she's considering making it as part of the course and a required read. I'm speechless. If I'm here too silent, it would be awkward on YouTube. But I was floored. And I'm also grateful that I finished all 22 chapters and several appendices of the upcoming book, Becoming a Death Doula. Where this, I cannot stress enough, I stress it again in what you're about to see moving forward, because this episode is looking at chapter 3 of book 1. I'll go over why it's 2 books shortly, but goes over the dying process. So here I finished all 22 chapters in Kindle format, and Kindle's very liberal on having tight margins, so you could fit a lot on a page. And it's granted, it's based on their device. So when I say 368 pages, that's reading it on a laptop computer. I didn't pull it up on a phone or on an iPad. But the Kindle version for a desktop was 368. So okay, let me see on a 6x9. So this is 6x9. 6 inches over, 9 inches down, give or take. I think they add a couple centimeters each way, but or I should say portions of an inch, since I said inches. Um, Let me put it in my template for 6x9, and then unedited came out to be 720 pages. Whoa, how did you go from 368 to 720 without adding anything? And it's because on a 6x9, you have what's called a gutter. So the gutter is this right here in the middle, and then you have your margin. So your margin here, your margin over here, margin on each side, and you have your gutter. And so when you add those requirements in that aren't present in Kindle, even the shortest book gets expanded in terms of how many pages. And that's unedited. So anyone who's been reading any of my books, I try very hard. I cannot say you're not going to have a case where, Peter, you had a paragraph cross up one page into another. And this gets especially hard if you have tabular data or certain types of information. But I try very hard. Like I want a case study starting on a new page. And there's lots of case studies in this book. I want the case study to be on its own page to start. Yes, I may have bullet points cross pages, but if I'm so close to the start of what's leading to bullet points, I want that to be on a new page. I want readability for you, my reader. So I'm going to put that as on its new page. And so when I went in, let me just go and see how bad can this really get. And by the time I got the final editing, not the final version, you can say final draft, like this is like 800 pages. Now, those of you before have heard me talk about like why I have done certain books in 8.5 by 11. I want this book to be 6x9. So I have 2 choices. Either A, I'm going to do an 800 page book. Put in perspective, this is 535 pages. So this book, which is Dementia Care Essentials, this is an extremely detailed book on going over what people with dementia can go, as caregivers, can go through. I know somebody could say rabbit trail, and you're probably right, but I just want to bring this up because doulas, you're going to be dealing with patients with dementia. Not saying you have to buy this book. There's others out there, but this goes over, financial and legal concerns that the family should consider. Validation therapy, which I cannot speak highly enough. Set of simple techniques that allow you to work with anybody that's having combative behavior. It works. You'd be amazed. You start learning and putting it into a habit, making a practice out of it, and you'll be using it with almost any type of engagement with with people around you. And you're like, wow, they're going to go, Peter, how did you handle that, or your name, whatever? How did you handle that so gracefully? Validation therapy. Naomi Fell invented it, not me. So credit where credit's due. Anger management in dementia. I want to rip my page. What about dementia patients wearing a CPAP and you want them to keep it on overnight? Not saying it's going to work all the time, but I give different ideas. External oxygen, how to keep it on, diabetes management. I'm just going over the majors: hallucination, infection awareness, getting them to take their meds, music therapy, nutrition, including handling the dysphagia issues, placement issues with working with the family on placement, habitual restlessness, which is different than reversible restlessness and terminal restlessness. So I'm going to shortly be, and yes, I'm going to eventually get there, but I'm going to go over chapter 3 and it's going to mention restlessness, and I'm going to make a commentary. There's reversible, treatable. DNR does not mean, and I say this again, I cannot say it enough, DNR does not mean do nothing and sit on your back end. If it can be treated, you could treat it. DNR deals with literally they're not breathing anymore. You don't have a pulse. That's what it's dealing with. It is not dealing before then. So they can get antibiotics. They can get if so anyway. Before I go on too many rabbit trails, there are 3 forms of restlessness that I'm aware of. Somebody may say there's 4 or 5. Comment, educate me. I love being corrected appropriately. But you have reversible restlessness, constipation, glucose levels, medication, urinary retention. There's reversible causes. There's irreversible, which is terminal restlessness. But you also have they're habitual restless. They can't sit still for the life of them. They've been this way their entire life. Habitual restlessness. Sundowning. When to call hospice. So this is 535 pages. So imagine if I added, and I don't have a book handy that I can say here's between this and that, it's another 300 pages, but imagine that. And some of you might say, I have no trouble having, several books, making it up. I have no trouble. The catch that I have as a book author is the print costs skyrocket. The print costs skyrocket. So I like to price my books at certain price points that I believe are affordable. And I know when I get this published, there will be some of you, Peter, you didn't price this high enough, and others are saying, you got to be kidding me. That's expensive. And I'm not going to argue with anyone, but I price them to what I believe fair. And the higher the print cost, because there's the print cost, the Amazon takes their cut, and I get a small portion of the royalties. I need what's fair for me for my time investment, blah, blah, blah. So I want to make that priced at an affordable point. So I made the decision, let me break this down into 2 books. Book number 1, Foundations in Practice, and the thumbnail of what I am planning on being the book cover is for each is on the thumbnail for this video. Book 1, Becoming a Death Doula, Foundations in Practice. How to start one from scratch. Book 2 is Business Growth. And I'm pausing because I'd love to be able to have, and so I know some people on Amazon get into subtitles that are humongous, which I know is not a dictionary, maybe it is nowadays word, but for keywords to try to increase sales. I don't do that because I like to keep it simple and smile approach. But this does get into not only business growth for book 2, but it also deals with client support, like how are you supporting the family during the active dying stage and during the different portions. And from a point of view, a person could argue that should be in book 1. I'm trying to balance it out. And who knows, maybe I will end up going, and it's right now it's 12 chapters for book 1 and 11 for 2, but book 2 is 360 some pages print. I may end up taking that chapter just after this video, just to move it over to book 1, and that will even out, by the way, the print cost. We'll see. But before I go too much further, there's going to be two volumes of this. The paperbacks should be publishing when I do publish them. It's either going to be this weekend or next. I want to do what I call a thrice over, a triple check. I've already did the once in formatting. I want to do 3 more checks. You may say that's 4. You're right. I want to do another check. The reason I call it 3 is I have to figure out if I'm going to illustrate or not. And if I illustrate, then it's 3 after the illustrations. I wouldn't count it is 4. But anyway, before I go that rabbit trail, uh, but I'm going to be putting them up on Amazon simultaneously for the paperbacks. Uh, and then shortly thereafter, the hardcovers. Amazon limits you to publishing 3 types per, I want to say per day until they get it published. So that could be 3 within 72 or less hours. So whenever they finish one, that leaves up a spot for you to put it to slide in another one. So all of these are going to be in paperback versions first for the 2 of them, then hardcover, and then Kindle in that order. Um, so be on the lookout for that. If you go to Amazon, you can. I'll put my author page is actually in the description of all my videos. You can follow me. I'm not saying you have to, but that way you'll get notified by Amazon. Hey, there's a new book out here, because this is 2 books I'm publishing in May for becoming a death doula. But in the plans, and fine, wish we lived in Hanover. That's not even fine print. For you aspiring book authors, and I shared this with somebody. I did an interview today with the person that we're looking on collaborating. I'm not going to say on what. She asked for privacy, but I was sharing with her, if you believe you want to write a book. I know so much I can write a book. You have probably 2 or more books in you. And one of my good friends, Noel, if you're watching this, hi, wonderful, wonderful registered nurse, former professor at Harrisburg Area Community College, uh, outstanding, outstanding character, outstanding integrity. I've learned so much from Noel. He's one of my mentors. But I've been trying to get him to write a book, and I'm like, plan for a series. So with this series that I'm planning for, and you'll know the name when I publish it, because I don't want to give out too much ahead of time. But I already have a plan. You'd start writing it, but I already have a plan on going in depth on case studies for legacies that I've done in hospice that death doulas can do. Because I noticed this on different different areas of my own research. Do legacies. And some of them, like if you do enough digging, you're going to find a framework. But I want to put that together, including my own experiences of what people really enjoyed, and put that into a paperback and hardcover book. I want to go more in depth on vigil planning and what a vigil looks like. And that's going to be more of a guide. Like both of these are going to, like, to me, if something is 200 pages or more, I'm calling it a book. You may call it a guide. If something is under 200 pages, maybe it's 150 pages or less, I'm going to call it a guide. That's just my own terminology. I'm not saying it's textbook terminology. So the vigil is probably going to be more of a guide, just giving you ideas, aromatherapy, music therapy, different things that can go into a vigil for your success as a doula. So plan a series. If you want to write a book, outline and plan, reach out to me. I don't mind brainstorming with you. Uh, Initial consult free, and then we'll see from there if it's, to what degree I can help you for free, or to what degree it might be consulting. But before I go too far, it's already 20 minutes on the intro. Let me go into chapter 3, and then afterwards there'll be the outro. This is an overview of chapter 3 of the upcoming book, and maybe published by the time you're watching this, Becoming a Death Doula, Foundations and Practice. Chapter 3 deals with the journey of dying. I've written articles about death and dying over the years as a hospice and palliative care nurse, and I know there are others there, like Barbara Carnes, RN, in her book, Gone From My Sight. Um, I believe this is a more detailed, granted, I'm biased. So I do have an introduction to the chapter, learning objectives, and we understand the timeline. Hospice is for someone who has a terminal prognosis of 6 months or less. Some people will confuse the words diagnosis with prognosis. They are not the same. Somebody having type 2 diabetes is a diagnosis. Or maybe they're told they have COPD, a diagnosis, or generalized anxiety disorder, a diagnosis. A prognosis is an estimate, and it is a clinical judgment, a clinical estimate. None of us are God but God. A clinical estimate of how much time someone has to live if everything goes its normal course. So if everything goes according to how it normally would, 6 months or less. And so while there have been times as a hospice nurse, I've even done this remotely. It takes practice. It's part art and it is part science. But when you've been doing this for a while, you will get to a point of being able to look at somebody and talk to them, because it's not just observational science. It is that those interview skills. What happened in the last 2 weeks, the last 4 weeks, the last 3 months, the last 6 months, and mapping that out literally on a calendar or on a notepad and putting down the dates and looking at how fast are these declines happening, the moderate to majors. The further out, you're only looking at the middle, the moderate, or the majors. When somebody's in the last week or two of life, you're looking at every subtle change. So hospice nurses, yes, we could tell a year out, sometimes a little bit more, but it gets easier to tell the closer they get to the 2 week mark. And I know there may be some viewers saying, yeah, if they're 2 weeks to live, almost anybody can tell. I've had family members not know their loved one was going to die the next day, and I go in and I couldn't say the next day, but they only have a few days. So moving forward, 6 months or less, there's decreased appetite, smaller portions. This is very universal with one fine print. I wish we lived in the world of no fine print. I've cared for loved ones with dementia, and if they were trained, like when my grandmother raised me, and I can't say I have this in practice because I've gotten away from it because it can be a bad habit. Not all habits are good habits. Finish your plate. She would tell me they're starving people in India. No offense to anyone living in India. And here I still remember my 102-year-old dementia patient who the family would brag. He finishes the entire plate. And this is at a nursing facility. And I had to watch my game face because they actually brought him a platter when they would feed him. He couldn't feed himself. He was that far advanced with dementia. Uh, that would be one of their meals would be 2 or 3 days for me. It was that big of a plate overflowing, and they'd brag that he would eat the whole thing. Outside of those particular cases, there is decreased appetite, preferences for softer, simpler foods. Dysphagia, which is that difficulty swallowing and chewing, is very common. More frequent episodes of nausea or digestive discomfort. And Rebecca, if you're watching this particular video, if somebody is doing larger portion sizes, they may spit out the food. And granted, in uh, that particular case, there was not 6 months or days. It can be difficult to witness. Um, I still remember my grandmother, anytime I wasn't feeling well, let me make you some tomato soup. and I grew up very poor, so that we didn't have a lot of meat, but sometimes there would be enough meat for half a sandwich to go with some soup. Uh, but we look at that food, have some chicken soup, just as a way we think we're going to heal them, but you don't ever want to force food on somebody who is terminally ill. There's fatigue, increased sleeping. On compassioncrossing.info, I do have an article that goes over sleep as a way to prognose. It's not the most reliable, but sometimes you'll have family asking questions. My loved one sleeping 20 hours a day. Does that tell you how much they have left? And there's a way to estimate it using that, but it's not as accurate. But again, if you want to look, compassioncrossing.info, featured category, how much longer, and then there's one on sleep. But if they're 6 months out, 12 to 16 hours is the most common. And as a death doula role, we need to understand this is natural, this is normal. We want to help the family understand that this is nothing to fear. This is part of the natural process. Under most circumstances, there's going to be progressive weight loss. Now, some of you watching this may go, my loved one, their legs are swelling, their feet are swollen, their abdominal area is swelling. And there are certain disease processes for the feet and what's called the dorsum, the top of the feet. That's typically due to heart failure. And I've had, if you're watching, I don't have heart failure, and then I'll ask, are you taking any medications for blood pressure? Yes, I am. Then you have heart failure. If your heart is not working correctly, you would not be taking any I'm not trying to be facetious. I'm not trying to poke on anybody. But if you're taking medications for anything to do with your heart's not working correctly. It is failing. You may not be terminal with it. And then with the abdominal, that might be liver involvement with ascites, or it could be congestive heart failure. With COPD, there's emphysema and chronic bronchitis. Sometimes they have both. And depending on which one you have, you may either be thin as a stick or barrel chested. But overall, there's weight loss for most. A lot of times, depending on their mobility, you may not be able to get weights. And as a death doula, you're not a medical support personnel. Not saying you couldn't. What's your weight? Uh, there are certain things I think are as gray areas. If you're not sure, reach out and ask. But you'll notice, clothing becomes thinner. Maybe the wedding ring slipping off or looser on their finger. For physical decline, reduced strength and stamina, increasing assistance for mobility, and more time spent in that bed or favorite chair. 3 months out, the closer they get, the more apparent things become. Not everybody has pain with dying. If you're watching any of these episodes, you may already have heard I help out a lot on the hospice and end of life group on Facebook. I've never added up the time, but I wouldn't be surprised if it was 1 to several hours a day on most days. And even today, somebody ended up private messaging me, which is perfectly fine. Are they always getting pain medication as they head closer to zero? The answer is no. I wish it was no more often. Most of the time, they are having increased pain. But I've had glioblastoma patients that they may have needed hydrocodone here and there, oxycodone for back pain. And I'm really talking, when I say here or there, I'm talking once every several weeks, not every couple hours. I still remember one of my Alzheimer's patients, not a single, no morphine, no, I think a year before they died, they were on for close to 2 years. They did have zero point 0.5 or maybe it was 0.25 milligrams of lorazepam. So there are cases where they don't receive anything. A good hospice does not push meds. We try to deprescribe as appropriate if the family agrees. But as a death doula, we don't give meds. but you're going to help the family in terms of noticing when they might be uncomfortable. So I don't go over the pain ad scale in this book. I do have other books planned in this series, but on compassioncrossing.info, there are several free articles about the pain ad. So the word pain, the letters AD, all one word. The word pain, the letters AD, all one word. It's a specific scale that was created for use for nonverbal dementia patients. However, I find that I, like as a nurse, I'd be using it all the time. And as a death doula, I plan to use that as a regular basis. Because if you asked the loved one on a scale of 0 to 10, how on, like, what is a 1? What's a 5? There's, and for somebody, they can say 10 out of 10, and to another person, the same pain as 1. And by the way, for the person saying 10 out of 10 might be saying, give me a Tylenol. And I'm not kidding. I still remember my patient in, oh my word, I forget whether they were in Glen Rock or, oh my word, I can't remember the name of the town that begins with an S. I'll probably remember it after the recording. It's in the area of Glen Rock. Oh, it's going to frustrate me now. But here, I was taking care of the daughter, rural hospice. I'm with home patients, and it's going to kill me that I can't remember the name of the town. But the patient has dementia plus a lot of other issues, and you know, we always are checking for pain. And she's grimacing, and you have the brows and the furrow, like right here. You're looking for that furrow, and she's grimacing, and I could see like a little tear. You look like you're hurting. And she said, chest pain. Is it radiating? And she nods her head. And in nursing school, we learned to talk about elephants, not just elephants in the room, but like there's an elephant standing on your chest. For whatever reason, I said, you feel like you have a horse standing on your chest. You feel like you have 2 horses? Yes. Okay, I'm going to go get the morphine. Any of you watching who are this channel who are nurses, you might remember the acronym MONA, M-O-N-A, morphine, oxygen, nitroglycerin, aspirin. So I'm going to go get the morphine because I know that's in the house. She wasn't on oxygen. I don't even remember. This goes back a couple years if we had a concentrator in the home or not. And I could have checked for aspirin, but morphine was, I'm going to go get the morphine. No. And it's like, it's not good. And I did education a lot before that. No. Okay. You have oxycodone. I'm going to go get the oxycodone. No. What would you like? Tylenol. I'm not kidding. Okay, I'll get you 2 one. She was it. Could I get you 1? And I got her 2 Tylenol. So the reason that I'm sharing this is even if you use number-based systems, if it's 10 out of 10, that may not mean that they need the strongest thing. This is very individualized. So as a death doula, we're not going to be worrying about what medication over time. And you have to be very careful of crossing the line. Scope of practice, drill that in. Scope of practice. Uh, you're going to be able to go and call the hospice provider, or let the family know they need to call the hospice provider and say, I'm with so and so, and they're grimacing, they're fidgeting. I really believe they're having pain. I can't give pain medication, especially like if you're the only one there. We need somebody to come out. I'm the only one here right now. I need somebody to come out. Now, this is where I wish we lived in a world without fine print. I can't say that the hospice nurse is going to say, I'm 2 hours away, give X, Y, Z. And that'll be between you and the patient and the family and everything else. But understand, if as a doula, you're going outside your scope. Um, I don't go into this in this book, but let me share with you, if you feel strongly that if you know you might be in those situations, you might want to receive further training, find out in your geographic area if you could be certified as a med tech. So in Pennsylvania, to be certified as a med tech, it is literally a few hours of training and you take a test and then you're certified. You're not licensed, you're a certified med tech. So check your state. Throughout this book, I have it in several places. This is not financial, legal advice. Talk to your people, look locally, but there are ways that as a death doula, but you're part of this too is going to be transparency. So when you do your contracts, your agreements, I am a death doula and I happen to be a med tech. I am a death doula and I'm a certified nursing assistant and I've been trained on how to give meds. So you would have that as part of your agreement, but you'll have to check the laws local to your geographic area. So be very careful with that. 3 month mark, increasing anxiety, especially if they're home alone. So, and yes, they could be home alone. I've had home alone cancer patients with very rapid moving cancers. Hospice tries to move rapidly in those cases to get them into a facility or to get somebody on board 24/7 there. But none of us have a way to wham and it happens. So you're going to see this, and you do want to, as a doula, you want to be documenting, you want to be journaling what you're doing. Now, I don't have, because Amazon, I publish on Amazon, they're very weird when it comes to fill in the blank pages. Now, there are some documents there, but I do have the book daily planner that is sold separately. It's under the caregiver support series, but this has where you can keep track of. In fact, there's the page where you can keep track of. They had a change in condition. Let me write that down, and let me keep track of dietary changes. So I'm not saying that you have to buy this on Amazon, but you'll have some way to document for the patient, just so the family's kept up to date. Everybody's on the same wavelength, including hospice. Uh, I mentioned with the restlessness. Now, I do want to mention, I want to focus here on fidgeting, trying to get up when it's unsafe to do so, picking at things not present, and just the generalized inability to get comfortable. While this is in the 3 month or less section, this is a time to really have hospice look into, is this because they're constipated, urinary retention, maybe there's medication issues. There's what's called reversible restlessness and irreversible. Irreversible restlessness is often referred to as terminal restlessness. Generally, you see that in the 2 week mark. I've seen it out as 4 to 6 weeks, but it can be in the 3 month or less mark. Just know to notify for a hospice on that. Um, and you might be saying, why don't I have that in this chapter? This is to teach. This book is not meant to replace a course. I've said that in previous episodes. I'm just trying to make it crystal clear. This is to complement a course or to bootstrap you to a point where you know you're going to be taking a course in the not too distant future, which might be a year or two after you start your practice. You're not under no obligation to me. I did mention here about indicating terminal restlessness, which might be, gee, they got a lot less than 3 months. 1 month or less, they were getting into more significant changes, cognitive changes, more confusion. They're becoming more disoriented. You may hear a hospital nurse or a long-term care nurse, you may hear they're oriented times 2 or they're oriented times 3. Orientation is times 4. Old school, it was times 3, but just giving you the current 21st century, it's times 4. So You're oriented to self. You know your name and you respond to your name. Now, human beings are not animals or pets, so please forgive me. But and my puppy's not in here. But if I call Bonnie or Penny and they respond, they know their name. If I go, hey, you come here, and they're not looking at me, they know their name's not you. So oriented times one, they know their name. Oriented times two, they know where they're at. Now, where they're at could be a big generalization in the field of healthcare. I know in central Kentucky would be considered oriented enough for most. I know I'm going to just pick the nursing home I worked during COVID. I know I'm in Manor Care Kingston Court, or I know I'm in room whatever in Manor Care Kingston Court. That's oriented to place. So if you're in it, you know your name, you know where you're at. That's times two. The next up is you know the approximate time. Now, in the most technical, that is, I know today is May 8th in 2025. Or if you want to be more forgiving, more merciful, like be more graceful to them, I know we're in spring heading towards summer 2025. Or I know we're in May. Or I know we're in 2025, and depending on the situation, you may give them a bone, so to speak. Now, if I'm doing a research to recertify them, this is separate from the doula. If I'm recertifying for hospice, I really have to look at uh, is my nursing gut telling me 6 months or less, and I'm going to advocate, and I'm going to go within the boundary. I'm going to stretch within the upper boundaries, and I'm being just transparent with you. So oriented times one, their name, times two, place, times three, time. Well, what's four, Peter? Well, oriented times four is they know the situation. Like I know I'm in Manor Care Kingston Court because I'm in rehab, or I know you're here to see me because I'm dying, or I have cancer, or I have this illness and I'm not getting better. So they're usually, when they're 1 month or less, most of the time they're going to be only oriented times two. And you may hear the hospice nurse, if they're properly trained, uh, uh, they're going to use the negative words. They're going to say disoriented times. So if they're oriented times two, it would be disoriented times two. Well, where do you get that? You take the two minus four. Or you might say disoriented times three, which basically means oriented times one. I'm not teaching that in the book. I'm just saying that if you hear a hospice nurse use the word disoriented versus oriented, it's just a negative way of saying oriented, and they're doing some math in their head to get to that number to make it basically, uh, I don't know of any way other than to say you're making it sound worse. Because when Medicare does their audits for eligibility, some of the auditors don't have any medical training, and if you word it too positively, they get kicked off of hospice. Oh, they're not dying, or they're not dying fast enough because you didn't prove that they're sick enough. And so that's the onus on the nurse. So, but moving forward, again, a month or less, they're going to, it's very common for them to see deceased loved ones, seeing places that are not present. They're 1 foot in this world and 1 foot in the next. A lot of times when somebody at this position, I want to go home, and you're saying, but you're already home. They're not talking about the home that they're in. Let that sink in. I want to go home. They're not talking about the room or the house that they're in, or the home that they grew up in, or if they're in a facility going home with their family, even if they brought it up before. 1 month or less, the majority of the time, they're talking about going home on the other side. That's very important. I can't stress that enough. And as a doula, as a human being, I encourage you explore their feelings. Tell me more. What's home like? And how does that make you feel? And explore their feelings and validate their feelings. One of the thing the as a doula, one of the most meaningful things that you will be doing as a doula, as a hospice volunteer, as a fellow human being, is going to be validating the experiences and the feelings of the people that you're with. You matter, and so do they. And right now, this is their journey, so you're there to support them, validate their feelings. Now, you may see skin changes sooner than the 1 month or less, but this is where it becomes more noticeable. You may go to touch their hand, and I like coming around the wrist. So I could also feel, the pulse, either the ulnar or the radial at the same time. But the skin's going to be cooler, especially the feet and the hands. The color changes, the lips and the nail beds. Now, for those who are uh, of a different color, I'm going to just say black because not every black person is African American. But there are ways of telling if they're pale. I don't go over that in this book. I go over in my hospice books. And if you want to know, please reach out to me. I needed to keep this book a certain length, and you can go into where you're just writing Tolkien's work, and maybe one day, I'm not saying there'll ever be Tolkien, but you'll increase sleep, 20 hours or more, drifting off in conversation. As you get closer to the 2 weeks, one of the things you're going to notice is they're looking through you and not at you. They're no longer tracking you as you move, and that's one of the ways you know they're looking through you. So 2 weeks or less, that's where they're typically transitioning. Now, I wish we lived in a world of no fine print, but you could actually transition for several weeks, up to a month. 6 weeks is unbelievably rare. It's possible. They're mostly bedbound, or maybe they're getting up and going to a bathroom or a bedside commode, but it's very, very limited. Speech often gets slurred. A lot of times families will say, I no longer understand my loved ones. Please pardon the blue, that's just grammarly with what they want corrected, but I'm happy with the way I wrote it, so I'm not accepting their certain correction ideas. And there's not a way to, unless I quit Grammarly. But anyway, they'll eventually stop speaking, and just, their hearing's the last to go, so they're always going to be hearing. You may hear some breathing changes. Now, the death rattle, and this book, like in Barbara Karn's Gone From My Side, I believe I go into more detail. I'm not saying my book is better than hers, and this is not a replacement. And hers is I'm going to give Anna Adams and others like Anna that does where she carries a bunch of Gone From My Sites with her, and she has her contact information at the back of the book. Wonderful business and marketing idea, Anna. Uh, but it's still a bird's eye view. Death rattles more often or not minutes to hours during the active dying phase, but you could start hearing that congestion as far out as 2 weeks. They're having trouble clearing it. They don't have the strength to cough anymore. And again, with any of this, number one, the part of the book is like to prepare you so that you as the death doula are not afraid of being with somebody who's dying. I'm really enjoying the international doula life movement classes I've been participating in. We talked about, acknowledging our own mortality, but until you've actually been with somebody that's dying, sometimes you hear this, you see this in action, and you're whether it's goosebumps or you got to take a break and ground yourself. It could be hard, and that's why I'm trying to give Here's what might happen. And with that, you could reach out to the hospice provider and let them know and let the family know and prepare the family. So their extended sleep, 22 to 23 hours, sometimes almost 24, is very common. Then in the final days, uh, there are times somebody could actively die while wide awake. I've had that. It is beyond rare. It is beyond rare. So in years of being a hospice nurse, I can count on, like, I think I had it once or twice. It is beyond rare. The majority of the time, they're in a comatose-like state. They're sound asleep and they don't wake up to pain or stimulation. I'm not saying they don't feel pain, but they won't wake up. That's where, again, you're watching the eye furrows. You're watching, are they having labored breathing? This is where, like, really educating the family and synergizing, synergizing with the hospice provider. There's going to be complete withdrawal. This is where there's going to be little to no food intake. And when we're talking about little to no food intake, if they're comatose, they're not waking up at all. You have to educate. I'm using the word "have to" loosely, but please educate the families. Uh, don't give food or water. As a hospice nurse, I've walked in and I still remember the son telling me, my night term nurse, she got a full syringe of liquid and no one else could do it. And when I'm interviewing and I'm there with the patient, was she looking like she is now? Yes. She's sound asleep now? Yes. She's comatose like this? Yes. And I had to, as politely as possible, say, if you were sound asleep and I squirted liquid in your mouth, what would happen? Aside from you coughing, and then it like dawns like oh wow, no, don't go there. So and again, this may happen earlier. Through parts of the book, I do mention other books I have written that may be of value. You don't have to purchase the book. In fact, I mentioned in the previous episode that this particular chapter goes into more detail than Whispers of Time. Where Whispers of Time does differently than this chapter and this book at large is it looks at how do hospice nurses know somebody has 2 weeks, 4 weeks, and so on without this level of detail. And so it approaches it from a different angle. So model skin, not everybody has modeling, but this goes over what it looks like or can look like. Is just circulatory changes. And it's typically on the hands and feet. If it starts going up towards the upper thighs and the hips, death is soon. Very, very soon if it's that high up. Temperature changes, last hours and final moments. And for those of you, and I adore Barbara Collins and I appreciate, I recommend every single thing she writes. But this is where it does get a lot more detailed. So last hours, the final moments, guppy breathing is so common. You have unresponsiveness. Towards the very end, the jaw relax, a fixed glaze if the eyes are open. Purplish blue cyanotic extremities. The fever resistant to treatment is known as a terminal fever. So I mentioned earlier before terminal restlessness. So when we use the word terminal restlessness, I made the point, you either have reversible restlessness, meaning that there's a cause we could treat, and DNR does not mean do not treat. DNR does not mean you cannot address it. So if it's reversible, we want to try and reverse it. We're not there to hasten death. We don't unintentionally prolong life, and somebody could argue, well, if you're reversing, you're prolonging life. But the catch is restlessness is uncomfortable. We're there to comfort. So fever is uncomfortable. So you're not going to give the med, but the hospice nurse may say, we're going to try a one-time round of a Tylenol suppository because they can't swallow it this time, or they might be using a Macy catheter, which it's like a urinary catheter in the bladder, but it's in the rectum instead. So they may give medications that way to just try to break the fever. And if it breaks, then it was a reversible fever. But if it doesn't break, then it's a terminal fever. They're going to keep on trying. The final breath, that long gasp, I've been there. I've been in cases where there's several reflex breaths, which if you've never experienced can be a little bit daunting because you think they took their last breath and you go up to approach them and all of a sudden they're taking a couple more breaths and you think, gee, did they come back? No, just give it 2 minutes. And one of the things to really stress is when they take their last breath, as a death doula, you're done from the charging perspective. You're done from the charging perspective. But and I give credit to Anna Adams and International Death Life Movement IDLM for the class that I took that just really fleshed that out. That's not to say that you cannot make arrangements on a consulting basis for Greenboro. That's a completely different thing. But anything after the last breath is zero charge if you're doing anything outside of very specific consulting and other arrangements that you may have done under a very transparent contract. Completely different story. So here again, going through the chapter, you're going to be supporting the family through the timeline. A lot of education and support. You're going to be reinforcing a lot of what the hospice nurse said. And if you believe you're there to advocate, you are there to advocate. And if you believe that the hospice nurse did not educate correctly, one, you are not there. I cannot stress this enough. You are not there to make the hospice nurse look bad. Let that sink in. You are not there to throw the hospice nurse under the bus. We are there to synergize with the hospice. But what that does mean is in private, you talk to the nurse. I think they need more education on XYZ, and maybe you do too. And this is fair. Can you please do that? And if they're giving you a hard time, again, you're not throwing them under the bus. You'll call their manager and say, I need additional help here. Your nurse is doing a good job, but they're not able due to caseload or other factors. But we need some additional support here. Who could you send? You're there to advocate, but in order for supporting your client and growing your business, you want to be synergistically as much as possible. So the emotional experiences are covered in this chapter as well. Fear and anxiety are unbelievably common. And I cannot stress enough, this is not just the patient, but there's going to be family members who are going through this too. And as a death doula, you're there for the patient, the caregivers, and the family. Anticipatory grief is very, very common. And I just realized I got to go back here and I got to remember to do the bold and italics. But that's one of the books I wrote for dealing with educating. How do you talk about death and dying? This does not replace at all the death deck and the EOL deck, which I think makes it more lighter, but this goes into different methodologies of having that conversation. Anger, psychology through the grieving process, coping strategies. I try to be thorough. Now, some of you may have say I had enough, I have it, and others are hopefully you'll be grateful that like, gee, no one ever went over this in as much detail as you. And in every chapter, I do try to have, where possible, and I don't know if I do have it in here. I got to, as we're heading down, culture and individual differences. I'm going to pause there. Understanding the family needs. I'm hoping to have this published between this week and next on Amazon. There's going to be 2 books, Foundations in Practice, which is what this chapter 3 is in, and then Business Growth. That's where I bring up marine burials, at least to a degree. Navigating the common challenges. You are going to be dealing with geographic issues. You're going to be dealing with different coping styles. You're going to have, I've had families, and you're going to have families where there's unresolved conflict. You don't have to do it all. Piece of advice, you don't have to do it all. If you're reading this book, oh my word, I can't see myself doing this, you don't have to. This is your business, your practice. You define what you're going to do. I'm just trying to provide the ground floor. Here's the material that maybe years down the road, you come back to this and say, now I want to start offering it. Now you have the tool. And then we have the end of the chapter and reflection questions. That's it for this chapter. Watch the outro. Thank you. Thank you so much for your time watching that clip, going over chapter 3, The Journey of Dying. If you have any questions, please, this is a non-judgmental channel. All questions are good questions. I'm going to be 62 in just a few days. And in all my teenage and adult years, I think I've only heard one question that I asked if that was a good question. Microsoft conference in my IT years where somebody asked how they would use the internet version of Microsoft Paint in order to make business decisions. But in all fairness, there's probably was a way to use it in a creative manner for that purpose. So please feel free to ask. If you like what you're seeing, please like. It helps the YouTube algorithm. It lets me know that I'm on the right track for the content that I'm producing on this channel, and subscribe. If you want to see a different discussion dealing in the categories I'm able to discuss, such as hospice nursing, holistic nursing, differences between palliative and hospice care, contrast, compare, Death Doula, or even a separate episode that goes off the beaten path, so to speak, and saying, okay, Peter, I want to write a book. I don't want to do the equivalent of a course on a YouTube episode, but like, what are some general tips and tricks, so to speak, I view my content as medium to high content, and we'll see where things go. But thank you so much for your time, and until next time, God bless.